Hello and welcome to Anesthesia Tools. Have you heard about patients waking up under surgeon's knife? Awareness under anesthesia is one of the most dreaded complications for patients as well as anesthesiologists. Patients report this failure of anesthesia in as much as 1 in 19,000 cases as per the recently published reports. But in patients with high risk, it can be as high as 1 in 100.
Public awareness about the possibility of conscious awareness under anesthesia is increasing in recent times. This has to be differentiated from hallucinations, dreams, or even false claims. Hollywood movies like the movie Awake, I think, re-emphasize this and has made it a big issue nowadays. Patients usually have a sense of awareness about their surroundings. That's usually during going to sleep or waking up from anesthesia. But this is not true awareness. Awareness occurs due to an imbalance between the depth of anesthesia and the extent of the surgical stimulus to which the patient is exposed.
Broadly, there are two types of awareness under anesthesia. One, explicit awareness. This refers to conscious recollection of events, either spontaneously or as a result of direct questioning. Two, implicit awareness. Implicit memories exist without conscious recall, but they can alter patients' behaviors after the event.
What are the causes of intraoperative awareness? It could be patient variability, problems with anesthetic side effects, unreliable clinical signs, or problems with equipments or drug delivery systems.
Each individual is unique because pharmacogenetics can alter the dose requirements of anesthetics. Genome analysis has shown different variations in the neurotransmitters and their distribution patterns. Acquired tolerance to anesthetic agents may occur. This usually happens in patients who are either high alcohol or high opioid consumers, or those who have had difficult airway problems, or those who have had previous awareness during their previous surgical exposure. The risk is also higher when there is concomitant use of muscle relaxants during the anesthetic.
It is well known that general anesthesia results in cardiovascular depression by means of either reduction in the systemic vascular resistance or direct myocardial depression. Hence, there will be some scenarios where, in the safety interest of the patient, the dose of anesthetic will have to be reduced. This is typically true in case of cardiac surgery, airway procedures, obstetric surgeries, and major emergency trauma surgeries.
It is assumed that light anesthesia will manifest itself by causing hypertension and tachycardia, as well as other signs of sympathetic nervous system stimulation, such as lacrimation, pupillary dilatation, and sweating. It is important to put these variables into the context of specific patient and their anesthetic. There are many factors that may cause blunting of these responses and therefore delay or prevent the suspicion of inadequate anesthesia.
The delivery of volatile anesthetics can be compromised obviously at different points. Inadequately filled vaporizer, failure to turn the vaporizer on, or even breathing system disconnections. Similarly, TIVA or total intravenous anesthetic delivery systems can also be interrupted either by blockade of the IV cannulae, disconnection of infusion lines, or even pump malfunction or misuse. This emphasizes the importance of thorough checking of the equipment and machinery before use and continued vigilance throughout the delivery of the anesthetic drugs.
Strategies to prevent awareness under anesthesia. Right from pre-anesthetic consultations, patients should be given a proper idea regarding the expected level of unconsciousness and the possibility of memory formation should be discussed. Patients usually confuse between general anesthesia and other modalities of sedation where consciousness or awareness is expected, like procedures done under local or regional anesthesia or conscious sedation.
Benzodiazepines can be used at induction, especially when there is difficulty expected in airway management. Titrating the anesthesia drugs to blood pressure and heart rate is fraught with problems. They shouldn't be titrated too low as the incidence of awareness increases. Instead, vasopressors and inotropes should be the drugs of choice. Ultimately, we also need to think about monitors for the depth of anesthesia to tide over this issue.
We often use MAC, minimum alveolar concentration, to help determine the depth of anesthesia because it allows us a real-time measurement of effect site concentration, assuming the end-tidal measurement equates the brain value. There are a few problems with the use of MAC to help with preventing awareness. The value is a median one, and therefore 50% of the patients may still move in response to the surgical stimulus. MAC does not refer to any patient's level of arousal, and therefore the likelihood of them being aware.
Electroencephalogram or EEG based depth of anesthesia monitors are designed to predict the possibility of awareness with recall under general anesthesia. However, this modality of neuromonitoring can also be used to avoid inadequate depth as well as unintended deeper planes of anesthesia.
The BIS or the bispectral index system uses a disposable 4-electrode sensor on the forehead which measures the electrical activity of the brain. It uses a proprietary algorithm to process the EEG data and calculate a number between 0, which is absence of brain electrical activity, and 100, which is wide awake. This provides a direct measure of the patient's response to anesthetic drugs. The target range of BIS values during general anesthesia is 40 to 60. This range indicates a low probability of awareness with recall.
The E-entropy monitor measures irregularity in spontaneous brain and facial muscular activity. It uses a proprietary algorithm to process EEG and frontal electromyography data to produce two values that indicate the suppression of brain electrical activity or depth of anesthesia: response entropy RE and state entropy SE. Response entropy scale ranges from 0 for no brain activity to 100 for fully awake, and the state entropy scale ranges from 0 when there is no brain activity to 91 when fully awake. The target range for entropy values is 40 to 60. Response entropy and state entropy values near 40 indicates a low probability of awareness with recall.
The NARCO Trend Compact M monitor analyzes the EEG data using spectral analysis and provides a number of parameters that gives us an automatically classified EEG. The EEG classification is from stage A, awake, to stage F, very deep hypnosis, with stage E indicating the appropriate depth of anesthesia for surgery. More recently, the monitor converts the NARCO Trend stages into a dimensionless number from 0, which is asleep, to 100, which is awake, by non-linear regression.
Patient state index PSI uses 4-channel EEG. It includes changes in power spectrum in various EEG frequency bands, hemispheric symmetry, and synchronization between brain regions and the inhibition of regions of the frontal cortex. PSI ranges from 0, which is asleep, to 100, which is awake. Cerebral state index CSI is a weighted sum of alpha ratio, beta ratio, difference between the two, and burst suppression. It correlates with the degree of sedation by an adaptive neurophysiology inference system.
Controversy still exists about the exact role of processed EEG devices as to how efficient are they in getting or gauging the anesthetic depth. Individual EEG responsiveness to anesthetic agents may be variable. Neuromonitors used to assess anesthesia depth or to titrate anesthesia delivery may not always ensure absence of wakefulness. Many monitors also have a delay which might indicate the patient being aware only after the patient has become awake.
Now, let us look at this topic from a different aspect. In recent times, published literatures give us a much clearer idea of the current incidence of explicit awareness. but the incidence of implicit awareness remains unknown. Hypnosis is one of the few tools capable of discovering the presence of implicit awareness and may prove useful in future investigations into the true incidence and management of anesthetic awareness. The therapeutic importance of using hypnosis to evaluate behavioral changes post-anesthesia is definite.
In as early as 1965, Levinson exposed 10 patients under deep anesthesia to verbal suggestions, suggestive of an anesthetic crisis. A month later, none of them could recall any of the events explicitly. However, under hypnosis, 4 of them could completely recall all the communication which happened under anesthesia. A further 4 patients developed partial recall of the communications under anesthesia, and they went on to develop anxiety. It appears as though under hypnosis, some people can actually recover the memories which they had during the anesthesia, which they normally would not have been able to do so in the awake state.
This also brings into our attention an important point. Each and every member in the operating room should be aware that when the patient is anesthetized, any poorly guarded statement can effectively be a negative hypnotic suggestion. So, we need to avoid negative remarks like he has cancer, he is likely to land up in ICU, he is unlikely to survive. A similar negative loose talk can cause terrible consequences later on.
In summary, the anesthesiologist should take the responsibility to prevent awareness during anesthesia using the best of modalities available.
All the staff inside OT should diligently avoid loose talk, as this may effectively amount to negative hypnotic suggestion for the patient under anesthesia.
Thank you for watching the primer to awareness under anesthesia. Until we meet next time with new topic, it's goodbye from Saneesh.